Today, it is my pleasure to introduce our speaker for today, Dr. Jantira Thomas. Dr. Thomas is the ACE Unit Medical Director and an Assistant Professor in Internal Medicine section on Gerontology and Geriatric Medicine here at Wake Forest. She obtained her medical degree from the Lake Erie College of Osteopathic Medicine. She completed residency training in internal medicine at St. John Medical Center and fellowship training in geriatric medicine here at Wake Forest as well. So on behalf of the Department of Medicine, please join me in welcoming Dr. Thomas.
Good morning, everyone. Thank you all for braving the roads to be here. My presentation is titled, They Try to Make Me Go to Rehab. And I wanted to start by giving a little background about myself. I am an assistant professor in geriatric medicine, and I have a unique position across care continuums for my patient. I work as a hospitalist at Davie Medical Center. I follow patients at rehab and in long-term care, and I see people in their homes for house calls. The title of my presentation isn't meant to keep you from sending people to rehab, because they really need to go. I hope with this lecture you walk away with knowledge that we know there are some people that do really well in rehab, and there are some people that don't. I hope after this lecture I can help you identify syndromes that better characterize patients who can benefit most and which syndromes can lead them to struggle more. So the learning objectives today, we'll start by describing geriatric syndromes that impact upon skilled rehab potential for older adults, identify effects of the post-hospital syndrome, best practices for discharge communication to the SNF, and review models of care for optimized disposition planning. I'll start with distinguishing long-term care from the SNF or rehab. I'll start with a clinical case. We'll define geriatric syndromes and their significance related to hospital and SNF transitions. We'll have another clinical case, and then I'll end with a review of current literature regarding best practices and innovative care models to optimize older adults' recovery after hospitalization. So in this slide, you see a man in a wheelchair in a hallway. He's in a nursing home. Is he in SNF or is he in the long-term care? This is likely review for many of you, but just by looking, you can't tell. SNF and long-term care may be in the same building. They may even be in rooms next to each other. A SNF, or skilled nursing facility, otherwise known as rehab, provides short-term care for patients requiring skilled care. This is rehab like therapy, wound care, or long-term IV antibiotics. It's paid for by Medicare Type Part A, and there's a maximum of 100 days. Long-term care is, like it says, long-term. It's for residents who are ADL dependent and require nursing care. ADL assistance is not considered skilled care by Medicare. In this lecture, I'm mostly focusing on the SNF side. So case number one, Ms. S., she's 85 years old. She had medical history of chronic atrial fibrillation, pacemaker, and dementia, and she was from a facility. She had 8 ER visits and 7 hospitalizations in the past year. Her usual hospital diagnoses were syncope and recurrent UTIs. When you look at this case, what do you feel is missing? How can we know what her baseline function is? What type of facility is she currently living in? And do we have a sense of what her needs are? So looking at her medical problems only, which is typically our focus in the hospital, she has history of syncope, orthostatic hypotension, chronic atrial fibrillation, dementia, recurrent UTIs, venous insufficiency, and depression. If you only look at her medical diagnoses, she may look like a reasonable rehab candidate. Let's incorporate her functional status from a geriatric standpoint. She also has history of falls and gait instability, incontinence, depression, anorexia and weight loss, moderate dementia, and she is from an assisted living facility with ADL impairment. These are common geriatric syndromes, and they exist before, during, and after hospitalization. Looking at this list, there are some things that we can improve with rehab. There's other things that require a different type of support. And then there's some geriatric syndromes we can address but cannot change. The key is these syndromes can be addressed in multiple contexts, and management of them can help us optimize transitions for our older adults. For example, if they're depressed and not participating or not eating and losing weight, it really impacts the benefit they can get from rehab. Regarding my patient's case, she had a significant number of syndromes and a relatively poor prognosis. She continued to decline. She actually fell at rehab. She had multiple intracranial hemorrhages, facial and pelvic fractures, and the last time she was hospitalized, she was immobile and really not interactive at all. She was bedbound, and she was unable to eat. So reviewing this case from a functional standpoint, she may appear more appropriate for hospice care. Use of Medicare SNF at the end of life. Almost 1/3 of older adults receive SNF care in the last 6 months of their life. 88% of these had SNF stays that originated in the hospital. 1 in 11 elders will die while they're enrolled in SNF benefit. Are we benefiting these individuals by sending them to rehab, or should we be focusing the conversation on palliative care options? Unfortunately, Medicare regulations prohibit dual enrollment in SNF and hospice for the same diagnosis. So when they're left to choose from the hospital, Medicare will pay for room and board if they go to rehab, but if they go to hospice, they're stuck with having to pay out of pocket for that room and board, which can be hundreds of dollars a day. Who's most likely to be discharged to rehab? If they're older or Medicare beneficiaries, longer length of stay, if they have impaired mobility and difficulty bathing in particular, and also living alone. That's more than twice the odds of being discharged to a SNF, the odds ratio of 2.23. Other factors may seem very psychosocial and not related to their medical diagnosis. The Medicare SNF benefit does not cover ADL assistance as skilled care. For these patients who mostly have psychosocial issues, there may be alternative care plans like additional home care services, and appropriate assessment of their functional status can really help you plan for that. So older adults discharged to skilled nursing facilities often have geriatric syndromes. Let's pause and define what that means. This slide includes the geriatric 5 M's to help you remember all of these geriatric syndromes. Dr. Mary Tinetti presented these geriatric 5 M's as a way to remember the key principles of geriatrics. Mind includes mentation, dementia, delirium, and depression, mobility, impaired gait and balance, and falls, medications, polypharmacy, deprescribing, and adverse medication effects. Multi-complexity, including the multi-morbidity and complex biopsychosocial situations we encounter with these older adults. And what matters most, assessing each individual's meaningful health outcome goals and care preferences. So geriatric syndromes are prevalent. Over 90% of hospitalized adults admitted to SNFs have them, and over half of those have over 3 syndromes. Studies have demonstrated a relationship between a greater number of geriatric syndromes and functional decline. The most prevalent syndromes are falls, incontinence, appetite loss, and weight loss. The most common cluster together is having the depression, incontinence, and malnutrition. In this chart, you can see that most of the patients had 2 to 3 syndromes occurring at the same time. Geriatric syndromes are associated with an increased risk of adverse outcomes, including functional decline, acquisition of additional syndromes, hospital admissions, and increased mortality. They're often under-recognized and seldom the focus of hospital treatment, and they're rarely communicated to SNFs or rehab on discharge summaries. Patients suffering from the post-hospital syndrome often have readmissions that are associated with these syndromes, not necessarily related to their medical diagnoses, and it's associated with worse outcomes, particularly if it's not addressed before they leave the hospital. Also, syndromes present before discharge, but they're rarely documented on discharge summaries. In a review of discharge summaries, 80 to 95% of syndromes were missing. The most frequently reported were falls and pressure ulcers, most likely driven by hospital quality improvement initiatives. This trend questions whether hospital providers are recognizing the prognostic significance of these syndromes. Could early hospital interventions on these syndromes help reduce the post-hospital syndrome? For example, recognizing depressive symptoms, reduced appetite, and weight loss could be communicated on discharge so that rehab could initiate active social engagement, supervision at mealtimes, and psych counseling. This could also be initiated when they get to the hospital. Case scenario number 2 is this very sweet 98-year-old lady that I met at rehab. She presented to the hospital with bright red blood per rectum and hypotension. Her past medical history was coronary disease, hypertension, hypothyroidism, and diverticulosis, and she had just started aspirin within the last 6 months for primary prevention. When she was hospitalized, she was diagnosed with an acute upper GI bleed. She had a duodenal ulcer found by EGD, and she had a couple of units of packed red blood cells. Her disposition was to an ALF, and once her acute medical diagnoses were treated, she was stable, and she was discharged home. She lives in a retirement home. It's basically an independent living. It's her own condo, and she can pay for additional services like people to bring her medications or to bring her meals if she requests them. When I met her, she said once she returned home, she sat down in her recliner, and she sat down for 3 days. At that point, her friends found her because she was unable to stand or transfer on her own, and they intervened, and she went to rehab. So considering her geriatric syndromes, at baseline she was ambulatory, but she was max assist at her discharge. She had gait instability and history of multiple falls, history of depression and urinary incontinence, hearing loss, and ADL dependence. She also lives alone. Her goals of care were to return home. How often do we meet these older adults that say, "I'm good, send me back"? She wanted to get back home, ambulate, and get back to playing double bridge with her group of ladies. She was also depressed. She felt like a burden on her family, and she was turning 99 the day after I met her. She's an example of an older adult who would benefit from rehab, but was not necessarily referred. Attention to these geriatric syndromes when she got to the hospital could optimize her disposition planning. In her case, she was evaluated by PT during her stay, and they had recommended rehab, but then her stay was prolonged because she had another bleed, she needed another transfusion, and then when she was stable, she was ready to go home, so she went. An important point from her case is she was from an assisted living facility, but it was really a retirement home where she could get additional services. If you discharge someone to an independent living or to an assisted living facility, they don't automatically get rehab and supervision. They have to have an order similar to like a home health referral to get therapy to see her. In this case, she did eventually complete rehab, but she had persistent deconditioning, and now she gets around mostly with an electric wheelchair. Hospitalization-associated disability. In reference to an article in JAMA by Dr. Kavinsky, she is probably able to ambulate, but I'm not sure. Over 50% of major functional limitations are not documented during their hospitalization. These syndromes are often pre-existent, and then when they get here, we make them worse. The medical conditions improve with our care, but function can worsen. This results in ADL impairment and subsequent inability for them to live independently. Changes in functional status are powerful prognostic tools and have been found to be predictive of mortality and other health outcomes during and after hospitalization. Functional status could be considered a vital sign and really is in geriatrics. Most frequent syndromes before and after SNF include depression, anorexia, weight loss, falls, and polypharmacy. Most of these syndromes do not show a significant change after rehab. This image is a little busy, but I want you to focus on the medium gray portions over to the right. This signifies the most persistent syndromes during rehab. They include polypharmacy and hyperpolypharmacy, really signaling an increased need to focus on that during the rehab stay. The last bar has the most dark gray. This is mobility impairment. This is the only syndrome out of the ones listed that showed a significant decrease in prevalence during their rehab stay. So next I'd like to discuss where we can intervene. Target syndromes like mobility, early therapy referrals, depression, medication and counseling, polypharmacy, optimize in every transition of care, and antipsychotic use, only in select patients and with a discontinuation plan documented. So starting with mobility, rehab helps mobility. If there are people with risk factors or mobility impairment, they should have a positive screen to be referred. Focused interventions in the hospital and rehab can emphasize early mobilization. In our ACE units, and specifically in the Davie ACE unit, we have initiated a mobility protocol where instead of fear of falls, we want to motivate to move. So at least 3 times a day, we make sure that they are getting up and walking the units, and if they can't walk yet, getting up to their chair. Our secretary actually goes around to rooms to check off how often they've done this during the day. Depression. There's so many of our rehab patients that once we see them due to their new impairments or after a long time away from home, they're depressed, they feel like a burden, and it really affects their motivation and their appetite and their success at rehab. So earlier interventions on this could really help them. Polypharmacy. 63% of discharged patients have a potentially inappropriate prescription at discharge. Polypharmacy leads to many adverse effects, including long-term cognitive impairment, more falls, more polypharmacy, unintentional weight loss, urinary incontinence, and delirium. Polypharmacy ideally should be addressed at all transitions. It can significantly impact other syndromes, and it's associated with these adverse effects. In particular, adverse drug effects consist 13.1% of 30-day preventable readmissions. Half of these are related to prescription errors, and polypharmacy and adverse drug effects can drive worse outcomes. These can be addressed in the hospital. One example of a particularly problematic class is antipsychotics. In a study, only 12.4 patients that were discharged on antipsychotics for delirium had an outpatient plan to discontinue them. 80% of the patients discharged with a discharge plan had a geriatrics or a psych consult during their stay. Overall, new antipsychotics should be flagged if they are new, and discontinuation plans should be documented. What about the post-hospital syndrome as a whole? This constellation of syndromes will affect which people will benefit most from rehab, which will struggle more, and who needs additional interventions to improve. As mentioned earlier, patients suffering from this post-hospital syndrome often have readmissions that are related to syndromes that are not related to their medical diagnoses. It's associated with worse outcomes and needs to be addressed before they leave the hospital. Hospitalization leaves them deconditioned, in pain, malnourished, stressed, and with disrupted sleep cycles. Some recommended interventions they've tried around the country include having them wear their own clothing. We often do that in our ACE units. reducing needles and unneeded procedures, optimizing their diet and pain control, reducing midnight wake-ups, and even incorporating more cheerful decor in the unit. In this survey, for a patient perspective on post-hospital syndromes, physical consequences were the most commonly reported, including weight loss. Over half of the patients reported weight loss during and after admission, and associated fatigue and weakness. There were also many motivational and psychological problems like apathy and a fear of falling. They expect to leave the hospital in better condition, but encounter unforeseen problems with mobility and self-care. More education could be given to patients regarding what to expect post-hospitalization and the risk for functional decline. Speaking of functional decline, studies have shown that the same patients that we are discharging to SNFs or rehab are more likely to be newly placed in long-term care. So functional decline. 1 year after hospital discharge, a third of older hospitalized patients decline in ADLs when they're discharged, and impairments can persist for 3 months to 1 year after. Discharging to SNF increases their long-term care odds by about 10% compared to people who are discharged home, who have odds of 3.6%. The same conditions that require SNF care may be the same that lead to long-term care. More attention is needed to these syndromes where we can intervene to help reduce functional decline that leads to this new institutionalization. Now here I have a cartoon, an elderly gentleman in a wheelchair in front of a long-term care facility, and he's saying, I'm getting the hang of this, wake up every morning, do basically the same thing with different complaints until I die. These same conditions are not what people plan for. Most older adults wouldn't tell you that they plan to spend the rest of their time in a nursing home. Over half of current long-term care residents experienced a prior hospitalization that left to a SNF discharge. Long-term care is a big decision regarding their quality of life and financially. From 2016, I have here average costs of long-term care. To share a room with someone, it's over $200 a day or $6,800 a month. To get your own room, it's even more. And if they're looking at assisted living, which is also out of pocket, that can be over $3,000 to $5,000 a month as well. Unless they have Medicaid or long-term care insurance, it's really out of pocket. Medicare doesn't consider ADL assistance a skilled service. How can we optimize these syndromes to avoid the functional decline that leads to this? Comprehensive care. So how do we do it all and do it well? We all have time constraints, the pressure to open beds and discharge quickly from the hospital, sheer workload of the face-to-face time with the families, with the patients, and all of the documenting. At max census, when I'm working over at Davie Hospital, by the time I finish rounding on everyone, the family meetings, addressing their acute medical issues, putting my orders in and documenting, there's really no more time. And in the morning, when the case manager says a rehab bed is finally opened and transport's going to be here in an hour and they need your discharge summary, how do you get it all in there? So I wanted to look at different models of care and ways that we could intervene. Some of these models of care are interventions by geriatricians, and others are with geriatric principles. To begin, I am director of our ACE unit here at Stick Center. There's ACE units that are designed for acute care of elders. They have geriatricians and geriatrics trained interdisciplinary teams that aggressively manage geriatric syndromes. Our locations are at the Stick Center and at the Davie Medical Center. A meta-analysis suggested that ACE units reduce the incidence of functional decline at discharge and increase the likelihood of being discharged home. ACE units can reduce hospital length of stay, and the resulting cost savings may be greater than the added cost of the unit. Inpatient geriatric consults. So the isolated consultation models where mainly a geriatrician performs a consult in the hospital have really failed to demonstrate significant effects on outcomes. compared to the interdisciplinary team models. And I think this makes sense because geriatric syndromes are complicated. They require a multimodal, interdisciplinary team approach. Mobile geriatric team consultations, where they took geriatricians and the interdisciplinary team members, had them consult with an initial brief geriatric assessment at the beginning of the hospital stay and follow during the stay, led to significantly shortened length of stay for these older adults and a significant early discharge from the ER. How could a geriatrics team help in the ER? How many times do you see people come through the ER and get admitted mostly for psychosocial issues? There's a SOAR program. This is from Penn Medicine. It stands for Supporting Older Adults at Risk. They actually have a trained geriatric nurse consultant that meets with the interdisciplinary team wherever they are in the hospital to focus and aggressively manage geriatric syndromes. They also help to optimize the disposition plans the entire time they're there in the hospital. I am most interested in the virtual care model. This includes mobile ACE units, interdisciplinary team meetings through video conference, and outreach to satellite hospitals where they don't physically have ACE units. The model of this care promotes interdisciplinary care and geriatric principles, but it employs technology which allows the dissemination of care and education outside the confines of the physical location. These are just stock photos of how I imagine it would be. So some virtual care models include the ACE tracker. This is Dr. Malone at Aurora Hospitals up in my home state of Wisconsin. I have to say I was really missing our snowblower this past week. But this ACE tracker, they actually developed it because a patient said, why can't I get ACE unit care when I'm at the other hospital? And how can we extend it to other people? They actually used Epic to generate a list of risk factors so that the people with the highest risk factors would be generated, and they would meet it as an interdisciplinary team and give their recommendations by reviewing the chart. At UAB, they had a similar circumstance where they wanted to extend their ACE care, and they developed the virtual ACE initiative. In that way, they could provide geriatric patients at other locations the same level of care as they get in the ACE unit. Project ECHO is across the country. It's in Canada. It's a model of telehealth. They combine telemedicine with geriatrics initiatives. And so they developed an online community of specialists like neurologists, geriatricians, psychiatrists, and other interdisciplinary team members. They communicate virtually through video conference. And through this platform, they go over cases. They provide education for primary care providers and for other learners from different disciplines. And they are researching outcomes. So here, this is a picture of my son. I have to say I was really hoping public schools would open today or yesterday, hopefully for tomorrow, but I have to admit I'm really going to miss him because he wasn't on rounds, but any patient he interacted with, he only brought smiles, and that's without any training at all. So we're going to have a discussion of how he does that. In summary, older adults are more likely to use skilled facilities. The population directed there might not be getting the full benefit. There's probably patients who could benefit who don't get referred. And novel programs to address geriatric syndromes during the hospital stay could optimize disposition planning for our older adults. Grab this here. I'd like to thank all of my mentors and advisors in putting this presentation together. And I'd like to end with the 5 M's, basically a high five from your geriatrics department that we can do this together. And I have to play the song. So, open it up to questions then.
So, Jantira, thank you. It's a great presentation. There's this huge healthcare system out there that we often don't think about. There are enormous numbers of older people who require a lot of help in long-term care, enormous. And I've always been pleased that your efforts and others are trying to integrate this a little better with, we think of the hospital as the center of the world, right? Really not. So I think a really important part of your presentation was the ways of integrating telegraphically or whatever, teleprompter, integrating hospital care, SNF care, assisted living, etc. How do you think we're doing on that, and what do you think are some of the major sort of things that are holding us back from really integrating? A lot of people come to the hospital today, and we really don't have a good perspective on how they've been in long-term care, and that perspective would shorten the stay and decrease the inappropriate things we do. So that's the question. How are we doing in terms of integrating all this?
I think because, can you hear me all? Working as a hospitalist, I think sometimes the easier decision is just telling people, you can go to rehab. This is the next step, without giving them really the full scope of things they could do in the hospital to go home, be more likely to go home, or what to expect during rehab and after rehab. I'm very lucky that I get to work in all of these different points of care. If I could, I wish I could bring all of the hospitalists over to see what rehab's like and what long-term care is like. I think that perspective would help. But I want to focus mostly on educating the patients and their physicians during their stay to talk more about other options. If it's mostly ADL impairment, what can we help them do while they're in the hospital? What kind of home services can we put together before they go home? Rehab might not always be the answer, but for our elderly, independent people who just want to go home, recognizing that they are having trouble. Just yesterday, I had an elderly gentleman that was stable and wanted to go home, but when I asked him to sit up in his bed and stand up, he couldn't do it. So we really had to sit down and have a talk about how this impairment can really set him up for failure if he goes home without intervention.
Bill, well, by the way, thank you for this presentation. I'm on the slide, but you did the work. It's a really great presentation. I think this question that Bill asked is magnified by, I hate to say this, but it is magnified by the RVU system. We only, if the team doesn't own the care, but only one individual owns that, it shows up mostly in these vulnerable patients, because they only own. I only own the patient when they're in acute care. Then Jantira only owns them when they're in subacute care, and it really fractionates the care for people, and especially vulnerable people. So, Bill, I think that's a major impediment to what we're facing. We just had a discussion in our own geriatric section yesterday about trying to overcome this, and we're all still thinking about it together. But anyway, that's one example.
Jantira, I've had some time to hang out on the CT surgery unit and also on Clancy Clark's service as the spouse of a patient. And both those units have different but very well-functioning mobility issues, programs. I mean, they're run differently, but they happen multiple times a day. And I know we've struggled to have that on our side, and we don't. So I'd like to hear some detail, if you're willing to share it, about how that dream might come true.
With our Davy ACE unit, for example, we had to meet almost weekly to generate what our protocol was going to be. And what we found is that we were really lacking in education, and that's education not for the providers, but for the nursing staff and the CNAs. It's so ingrained in them to have this fear of letting patients fall that they want to keep in bed or in chairs. That's been researched as well. And so educating them on the benefits of mobility, including reduced pressure ulcers, decreased length of stay, less deconditioning, was very pertinent in getting their buy-in to participate in this protocol. So that was the first step, educating the staff. If you don't have enough CNA and nurse buy-in, you're not going to have enough bodies to help you do it. Other programs, they were able to enlist volunteers that do mobility only, so people that actually walk your patients. That's a part that we have difficulty with as well. Some of our attendings actually walk with their patients on rounds. That's a way to do it. And the other part of our protocol was a wake-up program. So every morning we made sure that they had their eyes on, their glasses, their ears in, the lights were on, the curtains were up, to get that day and night perspective in.
A little bit of an extension on that. I'd love to motivate to move. I'd love for that to become a kind of an institution-wide theme. In the cancer center, for example, on our floor, we have a CMA. We'll walk through people every day when she's here. But when she's not here, there's no one that does that. Mm-hmm. I feel like, as you said, we train our patients to be afraid of falling. And instead of motivating to move, which is a much more positive approach, we really create a level of caution, which is a short-term gain for the hospital. We avoid those falls, which are bad news, and the nurses are very concerned about. But we really gradually weaken the patients more and more. In the long term, it's not in their best interest. And I feel like we create that sense of fear that carries with the patient when they go home, because they realize if they fall, they're going to end up back in the hospital, and then they rapidly deteriorate when they go home and they're not active. So any ideas on how we can motivate to move more of a theme throughout the institution? You somewhat addressed it already.
Yeah, I think the other component of buy-in, besides educating the nursing staff, and by the way, I completely agree with everything you said, but providing education for the patient and for the families. We're working on developing flyers that are similar to what other systems are using, but just educating them on the benefits of mobility, the risks of staying in bed. Something I do personally every time I meet someone is let them know, you do not have to stay in bed just because you're in the hospital. One of my colleagues from the Geriatrics department, Dr. Barbara Nicholas, she focuses a lot on physical function. And something that she said, being someone that doesn't work in clinical work or in the hospital, she said, why is there a bed in the hospital room? Why couldn't we tuck that bed away for the rest of the day? We don't lay in bed all day when we're at home. So I think there's multiple things we could consider.
Jantira, that was a really nice presentation. I think you brought to light a lot of issues that are often not part of kind of traditional medical curricula. I was struck by the slide that you showed on antipsychotic use after hospitalization and the very strong association with geriatric consultation and stopping an antipsychotic. And a lot of most medical education focuses around individual clinical conditions, and we don't have great training in thinking about syndromes mm-hmm. that are a little bit more, difficult to define. I was wondering what your thoughts are on, so the need for that type of thought goes well beyond patients on the ACE unit, has been highlighted in some of the earlier comments. I was wondering, what your thoughts are on how do you, try to mobilize that expertise on a much broader scale than, can be, delivered by the section on geriatrics.
I think something I found helpful just this past week, we had a patient discharged to rehab that was seen by psych during their stay. And right in their template, they include kind of a BPA of they've been started on a new antipsychotic and we need to discontinue it. Not everyone gets a psych consult. So to answer your question, what can we do? I think that similar to someone that's had an advanced care planning discussion and that BPA pops up that they should be referred for palliative care, something like that. If you start a new antipsychotic or if they're on multiple antipsychotics, they should be considered high risk and consider a psych consultation. Or even on the discharge summary, kind of everyone has their own, but incorporating that as part of the template, as part of something as important as the discharge physical exam or their discharge diagnoses, but including a part, if they're on high-risk medications, including antipsychotics, this was our assessment and our plan for discharging them afterwards.
I have a couple more questions, Dr. Lickstein. Dr. Widerski back there as well.
Well, thanks. This was really really interesting to me. I think assigning an elementary school student to each ward would be very helpful.
Yes.
So we could have done that during these snow days, maybe.
I know.
So as a medical director for a hospital floor where length of stay now is a huge preoccupation for us, I'm just wondering if we got some type of get-up-and-go program going, let's say on 8 Ardmore East, would you predict that we could get staff focused in that direction and that we might see an improvement in length of stay?
I do. I think this presentation, one of our doctors, Dr. Zamora, put together just a very brief PowerPoint of current literature and important facts like mobilizing actually decreases fall risk, helping the staff be educated so to dispel some of the myths associated with getting them up. I think that would be the most important part, the education to the staff. But I do think it would show decreased length of stay and decreased falls.
Before that next question goes, so we are on 8 Ardmore. Dr. Clark's, the surgeons, he is using spot technology. We thought it was just to cause security. He's using it to actually monitor mobility on that cancer center floor. And we're about
spot must move.
Your spot where we're put on we are we're about to start testing that on 2 other units. And so just so your wish may come true. Great.
There's actually a study in the one of the veterans hospital that they found that on average their inpatients were in bed almost 80% of the time, and this was using not just accelerometers but inclinometers, so just measuring even when they stood up in bed or sat up in bed, not just when they were walking. So it's really sad, almost 80% of the time being in bed.
Jantira, outstanding presentation. Thank you very much. One comment and then one question. The comment is that other disciplines are actually starting to get it. A lot of the things that you've just said. For example, at Davie Medical Center, Brett Nix and Matt Klein have applied for American College of Emergency Physicians geriatric accreditation for our emergency department. The application's in. For applications accepted, will be the second ED in the state of North Carolina to be accredited by the ACEP. Just an entry-level accreditation, but they have higher levels where exactly what you talked about, having an interdisciplinary team in the emergency department will hopefully help us out at Davie Medical Center. I'm hoping that spreads to other Wake Forest locations as well. The question I have is about hospitalists. Being in hospital medicine for many years here at Wake, I was wondering, because it's hard to go back to get geriatric fellowship, but I was wondering what you might think about maybe a geriatric certificate program where there might be some intensive geriatric experience and education so that maybe hospitalists in general within our system and maybe even more broadly than that might get additional training where we can be the champions in hospital medicine for bringing the geriatric principles to different hospitals.
I think even having, I totally agree with you, Rich, but to answer your question, what can we do for hospitalists? I think having, say, a mini conference, I think we have before through AHEC, but just saying what we do in the ACE unit and going over these geriatric syndromes and giving them kind of small bites to get an idea of what we do. As I said in my presentation, I have a lot of faith in geriatricians, but it's not just the geriatrician. It's really the team and interdisciplinary approach that helps these older adults.
There are fellowship spots available, though.
And to piggyback on that, there are some programs. Rich and I were talking about the program at SUNY that is doing dual training in hospital medicine and geriatrics. And so essentially people have a hospitalist position that's split with a geriatrics fellowship position. So 2 people, 1 position each. And so they divide their time and then graduate after 2 years with a certificate in hospital medicine and a geriatrics fellowship and able to sit for the board. So I think innovative models like that may bring those to life. And our Geriatrics Principles for Specialists model was one that we had used, and the Reynolds Foundation funding has ended, but There are models for that. Two quick comments, Jantira. Thank you for this presentation. A lot of hard work on your part. I think tapping into our interdisciplinary team is something that's incredibly important. Bringing other professions to the table, specifically pharmacy, with regards to flagging the antipsychotic use may be something that's disseminatable across the healthcare system. Having folks recognize when these are new medications and reminding the providers of the black box warnings related to these and how we can wean them would be one method for doing that. And then also just thinking about other models that have incorporated members of the whole team. Kelly Flood from University of Alabama at Birmingham does a wonderful training session with the nurse assistants where she says, what is it that you do when you get a patient out of bed? You are actually saving their life, because the amount of immobility is strongly associated with mortality at 1 year. And in an era where we're focusing also on retention of our staff and fighting burnout, finding meaning, this may be a way for us to rally around patients while also continuing to find meaning in our work at every level and every professional definition.
Thank you, Kate.
Well, thanks everybody for coming out. Don't forget to fill out your surveys and drop them off outside. Thank you.
Hi, nice to